Yeah, so though we do not have any evidence yet for cardiogenic shock on devices, definitely this is what we are working towards. But my talk is on current management of pulmonary embolism. So 50-year-old woman with acute shortness of breath, obesity, blood pressure is 95 over 60, SATs are 85% on room air. And this is the scan that you can see. There is definitely a bilateral pulmonary embolism. You can see on that the clot, major clot as a saddle thrombus. But she's still hemodynamically stable. So what should we do? We took her to the cath lab actually and put an Inari. You can use Inari with the flow retriever or not. And this is a 20 French guide catheter with a Amplatz wire here, and we just aspirated that, and looks very good post aspiration. And then this is the left side, and left side also looks very good afterwards with a very good pulmonary vasculature now that is visible. And this is the clot that we were able to obtain from that patient. And that's how you can give back the blood that you drain. And then you can actually see that this patient's clot burden was very large. And heart rate initially was 137, 91% on 5 liters nasal cannula saturation. PA systolic pressure was 56, which has come down to 24. Oxygen saturation 98% on room air, and heart rate still is slowly coming down to 113. And this is a second patient that we did similarly, actually. So excellent result after, pre and post, and this is the right side pre and post. And again, 95% on 2 liters came up to 100% on 2 liters, and PA mean pressure was 40, which came down to 29. So in the United States, about 900,000 patients have a venous thromboembolism, about 150 to 200,000 have pulmonary embolism, and 60 to 100,000 patients die secondary to pulmonary embolism suddenly. And this is the third leading cause of cardiovascular death. And I think we need to approach it properly, risk stratify them, anticoagulate as soon as you think that there is a suspicion of even pulmonary embolism, and the catheter, the other types of modalities of managing them is catheter-directed thrombolysis or full dose systemic thrombolysis, or reduced dose in people who have contraindications or somewhat contraindication for thrombolysis, and catheter embolectomy, which I showed you, and surgical embolectomy and mechanical circulatory support in dire patients. So there are variations and ambiguity in treatment recommendations similar to cardiogenic shock. In clinical guidelines of various societies differ. ACCP or AHA and ESC have different recommendations. The concept of multidisciplinary team is the most important one. Pulmonary embolism response team or PERT team has been brought up as similar to shock team and looking at various structures. So this is our national PERT consortium, which we are part of as well. As soon as the PE is suspected or diagnosed, activate the PERT activation via central telephone or pager. And there is a PERT leader that is on call of interventional radiologists and interventional cardiologists. We rotate at our institution, and we get a report of the labs, imaging, and the bleeding risk. And immediately the conference call is made, and we come up with a plan that is executed. So if the patient is stable to move, then we go for a CT scan. If the CT scan is positive, a bedside echo is already done. And if it is RV to LV ratio is more than 0.9 and there's a large amount of thrombus, we take the patient to the cath lab and do a thrombectomy with catheter base. And if the patient is not stable to move, obviously you do a transthoracic echo and then actually refer to PE algorithm treatment. So the other one is D-dimers, which are low and intermediate risk patients. They can be managed with just anticoagulation in majority of the patients. So risk stratification is based on echocardiogram, based on CT scan and RV volume size and RV overload that you can estimate. And in people who have high risk massive PE, hypotension, do not waste any time, give thrombolytics. Systemic thrombolysis has actually saved more lives than not in high-risk patients. In the absence of hypotension, further risk stratification can be made with the troponin or BNP, but don't wait too long. But based on CT and the oxygen saturation, we actually nowadays start taking these patients immediately to the cath lab. And you can also look at the severity index of pulmonary embolism. Dr. Pratap is coming, so I'll quickly move on. Anticoagulation should be started on each and every one. Okay, there is no doubt about that. Patient suspicious of PE or proven to be PE. Systemic thrombolysis in people who are high risk PE, meaning hypotension, give systemic thrombolysis. If there is a contraindication for systemic thrombolysis, you can give half dose lytics. That is better than nothing at all in these people. So the risk of similar to our thrombolysis in the contraindications which are normal for any indication for thrombolysis, please look at that. Catheter directed thrombolysis. You can put 2 pigtail catheters and deliver TPA at 1 milligram per hour over 24 hours. That is also can be done. But we use ECOS, which is ultrasound directed catheter thrombolysis, but which is supposed to be slightly better. And in small studies, it is better than putting a pigtail and delivering thrombolysis, delivering tenecteplase place. But surgical embolectomy, very rarely it is done, but even though it is recommended, people do not want to take these patients to surgery because they can die. But in younger people in our hospital, our surgeons have taken patients who have a clot in transit or such patients, they actually have taken to the OR and opened up and extracted the entire clot. Mechanical hemodynamic support, I think in the patients who are being high risk and going for surgical embolectomy probably need some mechanical hemodynamic support, whether it is ECMO or RP impeller can be placed. IVC filters post PE management, you need to place an IVC filters if they have high clot burden still or high risk factors for DVT formation as well. So you know that even I think an Indian cardiologist recently had a PE and after a travel. So please be careful whenever you travel. Sometimes people do recommend taking an aspirin. As such, I do not take that actually. So the treatment algorithm, as I said, anticoagulation for everyone with heparin suspicious and thrombolysis in people who have high risk and catheter-based thrombolysis, directed thrombolysis with the 0.5 to 1 milligram per hour of tenecteplase each pulmonary artery for 24 hours and repeat a CT scan. That is in intermediate risk, and low risk patients can be managed with anticoagulation. And intermediate risk patients who do not respond to catheter directed thrombolysis, or if the clot burden is large, like such as saddle thrombus but not hypotensive, can be taken to the cath lab and do a Inari or a Penumbra. Penumbra is smaller, it is 8 French. The one I talked about Inari, which I showed you, is 20 French, and Angiovac is actually 24 French. So these three are being studied in multiple studies, but I had slides. I'll stop here as we do not have any more time to discuss, but follow up these patients very carefully with the CT scan and right heart catheterizations at 1 year. The idea to treat these patients is to make sure they do not get pulmonary hypertension post PE. Thank you very much.